Welcome back, everyone. My name is Dr. Beth Darnell, and I am both a speaker and a moderator of this session on digital health. So this particular session obviously is thematically aligned on digital health, and we're going to be talking about innovations for receiving healthcare in online and mobile phone formats and opportunities for global adoption. We're going to have a discussion about the need for patient data safety, portability, and patient-centered considerations for the future of digital health. And we're going to be talking about challenges and opportunities for digital health in developing countries. Our first speaker is Anupam Kashyap. He is the Executive Vice President for Strategy and Product at CureMD. Anupam is the only speaker in this session who is presenting in a recorded format. So I believe we will go to his recorded presentation now and then come back for the live speakers afterwards. Thank you.
Good afternoon to everyone in Rome and worldwide. My name is Anupam Kashyap, and I'm the innovator at CureMD, a healthcare tech company in the United States with a global team on a mission to save lives. The world has changed so much in so little time. Just 20 years ago, we could not use internet and phone at the same time. Mobile phones only made calls, and social media platforms did not exist. Today, over 60% of world's population is using internet, compared to 6% 20 years ago. The smartphones are literally mini computers in our pockets, providing anytime, anywhere access to the world. Social media is how we get our information about the world and how we connect with each other. These changes are presenting opportunities and challenges for the future of digital healthcare. A future that should work to transform humankind to live healthier and longer lives. The digital transformation in healthcare industry, however, has been relatively slow, especially for consumers. But when the pandemic hit us in 2020, healthcare digitization got a much needed booster shot. Telehealth was adopted almost instantaneously. Online booking, vaccine management, and contactless check-in became part of the new normal. Contact tracing became a reality. Access to health records at hospitals treating critical COVID patients became a necessity. The pandemic not only forced us to accelerate digital adoption in provider and hospital settings, but also forced us to think about how critical it is to empower and enable patients to take control of their data, their health, and well-being. In the same 20 years, for every person that died of old age, 3 people died of the top 10 diseases. Life expectancy in the United States alone dropped by 1.8 years in 2020, the highest drop in the past 75 years, and another 0.9 years in 2021. While COVID-19 contributed 75% towards this decline, heart disease and cancer continued to be the top 2 causes of death, despite major improvements in detection, prevention, and care. While we have made notable strides in digital transformation, we need to increase the pace to develop digital solutions to combat and prevent such diseases that are creeping up in our lives with little to no notice. Let's talk about a few challenges. From a physician's perspective, between December 2021 and Jan 2022, nearly 2,500 US physicians responded to a survey conducted by researchers from American Medical Association, the Mayo Clinic, Stanford University School of Medicine, and the University of Colorado School of Medicine. The researchers found that 63% of physicians had at least one manifestation of provider burnout in 2021, compared to just 38% a year before. Also, the percentage of physicians indicating they would choose to become a doctor again dropped from 72% to 58% in just 1 year. When physicians show empathy, it can forge deeper connections with patients, leading to greater professional satisfaction for the physician, and the patients are more likely to follow physicians' advice when they know you care about them. Yet, in general, the physicians seem rushed, distracted, or trying to squeeze too much in one visit while simultaneously entering notes on the computer. Despite growth of value-based payment models, the reality is that majority of care still goes through fee-for-service payments in the United States. Primary care providers are supposed to be our quarterbacks of healthcare system. Yet, how many of you have spent more than a few minutes during an annual visit? How many times have you received a reminder from a primary care office about your annual visit or preventive screening? I think my dentist loves me more. They would text me, call me many times to make sure I visit them. They even send me a birthday greeting, and I know why. They love me. I help them make a couple of $1,000s in a year. On the other hand, primary care doctors make a few $100s. So primary care has to see a lot more patients in the same amount of time. Despite all great intentions, is the incentive enough for primary care doctors to connect with me, educate me, enable me to lead a healthier life? Now let's look at the consumer side. With rapid adoption of social media, information and misinformation became easily accessible and hard to differentiate. That has led to increasingly polarized and mentally stressed societies. Education. Unfortunately, majority of consumers are ill-equipped with the proper resources and guidance to proactively manage their health. I believe there is a serious systemic problem of how we equate healthcare to being a patient. Health and wellness is not taught in our schools. We spend all our childhood and early years learning professional skills to make a living and contribute to the economy, unable to care for our health because we get too busy with work. And when we are forced to learn, we see an overload of information and misinformation, leading us to spend the third or the fourth chapter of our life fighting diseases. We are also creatures of habits, good and bad. Our habits, combined with the lack of knowledge and what actions and inactions have the most impact on our well-being, is contributing to poor health. While physicians are focused on clinical results, different consumers have different motivations to achieve those results, to work towards those results. From needing to be independent so they can cook their own meals, to holding their jobs, to spend time with their grandchildren, or to feel good about themselves. The motivations play a huge role in achieving desired clinical outcomes. Well, the good news is that these problems can be solved when we work together, both in digital and physical world. We have to identify and focus on social, economic, medical, and environmental factors that have the most impact on the quality and length of our life, such as food supply, environmental policies, access to new therapies, financial and cultural barriers. We have to create much needed awareness, skills, and healthy habits to engage people with information and resources, not just locally, but from around the world, to develop systems to support early interventions. I see a world in not so distant future where people of all ages are informed, engaged, and enabled to actively participate in their own health with digital solutions like LEAP. We started LEAP, a project to extend life, to add years to the life and to add life to your years. LEAP is creating a digital health ecosystem, giving people and their caregivers secure access to their universal health data, identifying automatically and scheduling preventive screenings, surfacing care gaps, and then connecting them with world-class education about their diseases and treatments, giving access to affordable in-person and virtual care, facilitating two-way communication with their healthcare providers and other people, other patients like them. We're also working on ways to predict disease such as diabetes, heart disease, and cancer using health data. Life expectancy and quality of life can be significantly improved with data-driven behavioral science approach by designing easy-to-use digital platforms to drive desired outcomes. I want you to stop and think about what a wonder our human body is, with intricate system of organs, DNA repair, antioxidant defenses, energy metabolism, recycle and maintenance. This wonder deserves to be cared for. Life is a gift that gives us a chance to explore, to create, to experience the wonders of this world. We can breathe fresh air, see the beautiful world around us, hear the music, smell the fragrances and the aromas around us, taste foods from around the world, and feel the warmth of our partner, children, and loved ones. Together, let's build a future when humankind got ahead of diseases like heart disease and cancer and began to push the boundaries of the life that we know. Thank you.
Well, we're going to get going as soon as the slides get queued up. Hi, I'm Sean Mackey. I'm delighted to be here with Dr. Beth Darnell to present on our life's work for the last 2 or more decades to develop a digital health platform to help transform healthcare, to generate high-quality evidence and to deliver tailored therapies for people based on their own unique characteristics. We're both from Stanford University, and delighted to join you here in Rome. So the vision for this, I'd like to summarize in these next few slides. I would like to ask you to imagine a world where clinicians have access to high-quality data to inform assessments and best treatments through clinical decision support systems, where data is continually being fed into the system, new data types added, they're dynamically added, and the system is continuously learning. To imagine a world where We have targeted assessments and delivery of online therapies that are based on a person's unique characteristics, their own data, and finally, to imagine a world where patients have access to their own health information to improve their education and management of pain, as well as other conditions. Patients receive online therapies, treatments for empowered system management, all from their own home. This talk is going to focus on a use case of chronic pain, but this is not a pain talk. We're both in the field of pain, but we've created this system that extends well beyond that of pain. But for the sake of our brief discussion today, we're going to focus on pain and tell you a little bit about the platform we've created that we've called Precise, a platform for research, education, care, innovation, support, and empowerment. It is a digital health platform in which we use data to identify and prioritize individual treatment needs and characterize the patient's trajectories to flexibly deploy online treatments. We assess the treatment response from each patient, and then we use the data also to deeply characterize people from real-world situations. One of the problems that we've seen time and time again, I think both in the talks over the last 2 days as well as throughout the world, is that we need better data. I co-led the development of the United States National Pain Strategy at the end of 2016, and one of the key messages we put forward is that better data are needed to understand the problem and to guide action. And I think action is that key word. We need actionable data. So we were driven by the findings of the United States National Pain Strategy and similarly pain strategies and other action strategies throughout the world to identify what the problems are. And what we've learned is, from national level data, we've learned the prevalence and the impact of chronic pain is astounding, but that data hasn't allowed us to draw actionable findings and to put something into action. That we have realized that patients lack equitable access to high-quality pain care, and that we need to capture high-quality data to characterize the treatment effects. So we put forward a solution, and that solution is to establish a secure, patient-centered learning healthcare system that characterizes diverse patients, real-world patients, and helps to develop global insights. That this learning healthcare system will ultimately longitudinally characterize each person in a real-world environment from diverse conditions, that we can apply proven and effective on-demand pain treatments, that we can treat pain early and ultimately help prevent chronic pain and human suffering. We also want this system, and what we've developed is a system for developing prediction models for both research as well as clinical purposes, where we capture real-world data from people that are often excluded from clinical trials. As somebody who runs clinical trials and has for the last 20 years, over 90% of patients in clinical trials are excluded because they have multiple conditions, they're on medications, they don't represent the real world. We also want these systems to deploy artificial intelligence-assisted target inventions that are equitably accessible for all patients and for all types of care, and that we want data to assist in epidemiologic, observational, and clinical trials research. So what we've developed is a platform that's based on a program called Choir. Choir is a learning healthcare system. It is an open source model that we've had in place at Stanford as well as in multiple universities in the US, Canada, and Israel. We're building on 12 years of experience with this digital healthcare platform. It is a mobile-first, web-based platform. We've tailored it for very specific pain conditions, but it's also been developed for chronic fatigue, GI, surgery, internal medicine, family medicine, and many other conditions. It's been efficient and easy to use. We've captured hundreds of thousands of patient assessments, over 30 publications. We provide it on an open source or free licensing approach. We've put it into the cloud to centralize its use. And we're delighted to partner with you if you're interested in this to help transform how pain is treated and how it's assessed, particularly in underserved populations. And with that, I'll turn it over to Dr. Darnell.
Thank you so much, Sean, and I'm delighted to speak with you about how we can better meet the needs of patients worldwide. You know, it's sort of a truism, not just in the United States, but in multiple countries, that will issue these reports about how we should best treat a health condition, whether it's pain, whether it's cancer, whether it's diabetes. There's lots of talk about what we should do, but there's very few actionable ways to implement on the things that patients need most. So we feel very strongly that it's time to stop describing the problem. It's time to start addressing the needs of patients in accessible and convenient ways. So in the United States, you know, we've been talking about how to best treat pain for over a decade. But again, these actionable and accessible ways to treat pain, largely inaccessible. Let me see if I can. Oh, here we go. So it's true for pain as well as virtually any health condition that we really need a whole person approach, a biopsychosocial approach, so that we're not just treating the disease itself, we're treating the person who has the disease. And that's so much about what the World Patient Alliance is about, with empowering individuals to best understand what they can do to help themselves. This is especially true when it comes to pain. We really need a biopsychosocial treatment approach. Now, evidence-based treatments exist. We actually have evidence-based, proven whole-person pain treatments that work really well. But here's the problem. They're largely inaccessible. They tend to be multi-session, sometimes 8, 10, or 12 sessions, 2 hours at a time. So we're talking about 16 or 24 hours of treatment time to empower people to understand how they can best help themselves. So we don't have trained therapists across the world who are knowledgeable in these treatments. We don't have enough clinicians to address the needs of patients. So what we need, again, are accessible options. And this is where I developed something called Empowered Relief, which is a highly compressed, single-session pain relief skills intervention that rapidly equips individuals with the information, the tools, and the resources to best control their own pain and symptoms. Over the course of 2 hours, people learn about pain, how it's best managed. They put the information into action in a personalized plan, and they walk away with a roadmap for relief that they can use in their daily life. So we've been studying this at Stanford University for, the past 6 or 7 years, and we have compared this one-session compressed pain treatment to these longer course treatments, such as cognitive behavioral therapy, and we have found that it works comparably well. So basically, we call that non-inferior. It works, one session, 2 hours, working as well as 16 hours, which is very exciting when you think about how patients have little time, our treatments are burdensome, we need things that are convenient and accessible, and we see that it not only helps reduce pain and alleviate suffering, but it helps reduce a whole host of symptoms that patients are facing when they have these complex medical conditions. Depression, anxiety, fatigue, sleep disturbance, all of these things 3 months later. So we're really seeing enduring benefits from a one-time informational session that is skills-based. So what have we been doing? We have been disseminating Empowered Relief worldwide. It's now available in 19 countries and in 7 languages. So we're really focusing on scaling this out in a way to make it accessible to every person who has pain worldwide. These are just some of the partners. We have a lot of research funding in the United States and in Canada focusing on this. So fortunately, we've got buy-in from sponsors who are similarly looking for actionable solutions to help patients right now, wherever they are in the world, because it can be delivered online. So that's how most people are delivering it online. And I just briefly want to tell you what else we've done in terms of digitization. We took the 2-hour Empowered Relief class, tailored it to people undergoing surgery and conducted 2 different studies on it when patients were in the hospital after surgery or at home before surgery. We studied it in women undergoing surgery for breast cancer and found that it reduced women's need for opioid pain medication after surgery. And then we studied it in patients undergoing orthopedic trauma surgery at Stanford University, and we found that this brief digital intervention that people receive on an iPad in the hospital after surgery reduced people's pain after surgery and also 3 months after the surgery. This is really important because some of these complex surgeries, patients have moderate to severe pain for months, for 3 months or more. How are we helping people recover after surgery to prevent the chronification of chronic pain and help people get back to doing the things that they love? This is a risk-free, no side effect type of intervention that people can get. We have now seen this intervention, Empowered Relief, integrated into standard care in payer systems and at the Cleveland Clinic in spine surgery at the Cleveland Clinic, so we're seeing broad-scale adoption. And then lastly, what we're doing now, we are funded by the National Institutes of Health to create a tailored version of Empowered Relief that is digital, basically app-based, and it's tailored to people who have opioid misuse or opioid use disorder. Now, this isn't a big problem in a lot of countries in the world, but it is a big problem in the United States. And so that study is active, and what we're hoping is that we will then, through this research and also dissemination, be able to offer high-quality, standardized, whole-person behavioral health care that's targeted to the intervention anywhere. They can receive it anywhere so long as they have internet connection.
Okay. Now, I want you to imagine that we take the best of what I've described with a digital healthcare platform, a learning healthcare system, and now you combine it with the type of things that Dr. Darnell just described with online digital therapies, and you bring that all together. And you bring that all together on a platform in which you're characterizing a person's real-world situation, their symptoms across pain, fatigue, sleep, anxiety, depression, physical function, you name it. And then from that, you're picking and choosing the best therapies that are targeted and aligned with that person's needs. Dr. Darnell has outlined Empowered Relief as one. We're working on many others. We've partnered with Penny Cowan at the American Chronic Pain Association to integrate in, through a partnership, the American Chronic Pain Association Stanford Chronic Pain Research Guide, so we can deliver targeted educational materials, and we're building yet other modules. And from this blending together, we can create Precise. We're looking to partner with people. Again, we're giving it away. We're not making any money off of this. We're going to start with English as the first language, and then we're also building out multi-language support. So our ultimate goal is to scale these high-quality evidence-based treatments on a global basis, worldwide, to reduce human suffering, as well as the clear healthcare inequities you've been hearing throughout this conference. We want to provide convenient home-based care. At this point in time, it does require having an internet connection. It is a web-based model, so it's not an app, but it's something that can be accessed through any browser. We can connect both patients and clinicians through Precise, and for those of you who are technical geeks, we can integrate into electronic medical records through something called FHIR, F-H-I-R. And we can use this to understand the individual patient's needs, their wants, and the responses to those digital interventions, and then use the data to further tailor therapies. We're also using this data aggregate for population-based insights. We've already done that with, as I said, over 30 manuscripts that we've published. And we use this to help give patients to guide decision-making and refinements of the directions of Choir. And specifically, the point is that this platform was created by patients for patients. It is all in collaboration with patients. So this is what we've been working on, what we're bringing together are decades of our research at Stanford to help try to make an impact in the world, to reduce pain, suffering, and prevent its occurrence. So I want to thank you for taking this very brief journey with Dr. Darnell and me to help imagine a world where, working collaboratively with patients, that we can create the world that we want to see, where we can use high-quality evidence to guide treatments, and then also give you real evidence-based therapies to make that impact. Thank you.
In a world of pure imagination, take a look and you'll
Thank
see.
you. And I'd like to introduce our next speaker, who is Jacob Coverstone. He is the manager and director of Neurovations Education Incorporated.
All right, we'll take a moment, I guess, to get the slides queued up. There we go. Hi, everybody. I'm Jacob. What follows are just my opinions. I have no financial relationships to disclose, and I put that on there as well because, as you're about to hear, I'm an instructional designer by trade, and making things like this is what I do for a living. So it's nice to be on the other end for a moment. The talk that I'm giving and kind of the challenge that I was given is really 3 talks. And I've been given 12 minutes in which to do it. So I'm going to do my best, and we're going to move a little fast, but we're going to talk for just a second and try to establish some shared definitions of what we're trying to mean when we talk about patient-centered healthcare, what we mean by engagement, what digitization is, and how that has all gone wrong. So if that's not of interest to you, here's really just where I'm going to end up. There's better ways to find solutions to things, but you actually have to start with the right problems that you're trying to solve, and especially when it comes to the digitization of healthcare, those were not the problems that were being solved at first. So as I mentioned, I'm an instructional designer. This chart that you don't have to care about is basically what I do for a living, but the crux of it is I am not the target audience for the things that I work on. The problems that I try to solve and design for behavior change are not the actual things that I will end up implementing. So how do you find solutions to problems that aren't your own? And that's what I want to talk about a little bit here. So part of that process involves figuring out what's actually going on. A literature review is a good place to start, and I did that for this talk as well. And for those out there who actually try to study making patient-centered care initiatives, it's interesting in this case that really the exploration of how to make healthcare patient-centered, and by the way, that being a transformation does imply that it's not already, which is weird, they realized that it's a systems change problem. And that's because we have a lot of large, complex, interwoven systems. So it's about empowering patients to pursue wellness in service of their life goals. This was not the beginning of their paper. This is buried in there. But it's about strengthening the patient-provider relationship, and it's about empowering providers in the work setting so they have the best tools available. And I'm enthusiastic about the tools we've already seen being presented. There's a lot of encouragement about the direction that we're heading, but that also signifies that it is kind of time for an overhaul of a lot of legacy systems. When you actually go on to say, well, how do you lead this? This is for patient-centered care. And patient and family engagement is the second point. I'm going to talk a bit about that, but that's really indicative of how we got here to begin with. And there's just a natural, egocentrism of whenever you're studying a problem to think that your part of that problem is the most significant. And I would like to challenge everybody here to think that whatever it takes in order for us to actually provide, even if it's a downstream effect, the best care to patients, that's the real problem we're trying to solve. We're not trying to solve the way that some of these systems talk to. Why are you trying to solve that? Right? So we're going to talk about a couple of universal design principles here real quick. Before you can actually develop a solution, you have to give up the idea that you already know what it is. That may seem obvious, but we've already spent 2 days talking about a lot of solutions, and a lot of those have been presented as if they are the solution. I don't have solutions, I have methods. I don't have the answer to this problem. I have ways of finding answers out, and each person needs to adopt their own methodology for uncovering and actually driving improvement. The other thing that you have to be willing to do is essentially shake it up. If everything was perfect, we wouldn't be trying to fix things and overhaul them to begin with. We wouldn't need smarter tools if the tools that we already had were smart enough. And as every new breakthrough comes along, it's worth actually revisiting and revamping and going back to the start and figuring out how we got into some of these places, because trying to avoid those pain points and legacy change is what's going to lead to the most pain downstream. And that just goes for life in general. But when all of that starts getting applied to the digitization of healthcare, I'm going to argue that healthcare has already been digitized. That's already happened. We've spent so mumuch time already talking about EHRs, old and new, and I'm going to keep talking about it here, quite frankly, because it's the central point when it comes to the utilization. I'm getting ahead of myself, though. But patients were not why we implemented EHRs. We have said that they were. It may have been argued that they were, but no. When you actually start to split up the digitization of healthcare, there are a couple of different aspects of it. I'm not going to go into the consumption patterns as much, but Dr. Mackey already touched on this a little bit, and by including some of the great work that the American Chronic Pain Association has done, for example, educating patients and empowering them to be a more informed, more collaborative part of that healthcare experience is important. There are organizations out there. I was listing Mayo and Cleveland Clinic here for what they have put out for their patient-centered materials. They're good examples. I won't have time to go into that fully, but I encourage you all to go look at their patient access sites, because they do a great job of providing vetted, quality information that is unbiased before or during that patient care experience. It helps to tee up that conversation from places that are not TikTok or Facebook. Overall, when it comes to digital utilization, that's where we get into electronic medical records. And not wanting to be Americentric, I actually tried to find out what the distribution of EHR systems globally is, and it looks like actually New Zealand was the first that hit 100% utilization for primary care physicians. But this is where the incentives, the nature of this, and really the customer experience start to warp things. Because this was a land grab 20 years ago. EHR systems were heavily subsidized, and the rollout, although it was touted for a lot of reasons as being able to solve a lot of problems, those weren't patient care problems necessarily. Those were problems that the stakeholders that had the decision-making authority presented. So they were built for those systems, for those individuals, and not to enhance the patient care. It was a given. Oh, this will just replace your handwritten records. It'll be the exact same. Well, it's not the exact same. And there's a lot of artifacts that were easy to program but don't really reflect the actual patient care paradigm. And I love the title of this just for how obtuse it is, but this article by Smith on healthcare information technology's relativity problem, a typology of how patients' physical realities, clinicians' mental models, and healthcare information technology differ, breaks down a few of these thematic paradigm problems. And one that I've highlighted here is name that cancer. So in the EHR system that they were evaluating for this, in order to make a referral to an oncologist, the primary care specialist has to specify what cancer that patient has already. There is no choice in that drop-down menu for I don't know, that's why I'm sending them to an oncologist. These are things that when you start to break down, it emerges because of the confluence of all these factors. If you were selling this to a hospital administrator and you were able to say, well, you're not going to have to actually employ as many billers and coders because your clinicians are now going to do all of that coding. They don't have to worry about the ICD-10, the HCPCS codes. We're just going to build a little drop-down in that menu. And they'll just select whatever that is, and it'll automatically do that coding for them. And that sounds like a great idea for the administrators until it starts being put into practice and how that actually starts to change the patient care experience. It's also one of getting good data and how from several degrees removed, you don't know if it's good data or not. It's just data. And when you haven't been able to aggregate that data until now, you don't have a good frame of reference. So as a quick digression, actually, I think you guys were there. We were putting on a program in Hawaii. This was a pain conference, and we had the Lieutenant Governor, Josh Green, who himself is a practicing physician, giving a presentation alongside with the Hawaii Medical Services Association. And they are the insurance provider for most of Hawaii, and I mean 87%. And someone in their quality improvement department was highlighting the fact that they had spent hundreds of thousands of dollars trying to study and figure out the root cause of a problem. And that's that apparently, as far as they could tell, in the state of Hawaii, the rates of left eye blepharospasm were something like 4 to 7 times that of right eye. It made no sense. And no other state seemed to have this problem. So they're trying to figure out, why is it? Why is the state of Hawaii why is this our problem? Is it that, well, in many cases, our roads are built in such a way that we only have roads on the southern coast, and so there's more sun exposure? No. In the drop-down menu in the EHR, left eye appears above right eye, and there's no unilateral choice. And so clinicians in the end were just only scrolling as far as they needed to select the code that would allow them to bill for the visit, prescribe what they wanted, and move on. But you couldn't tell that just by seeing the aggregate data. The frameworks for these interactions start to shape and distort the interactions themselves. And the patient care experience is becoming increasingly clerical because those in the clerical roles are essentially not being employed anymore, and it's being delegated to the clinicians, and the clinicians have to spend more and more time focusing on those aspects. And when you actually start to look at what patients like out of a visit, or what matters to them in that healthcare experience, access, communication, the personality and demeanor of their provider, the quality of care, the handoff and the facilities start to emerge. There's nothing in here about billing and coding, guys. And it's a shame because it starts to warp a lot of these things. And this is where we get into that's just the basic principles of how we got into some of the decision systems that we're in and what we've been baked into. But fundamentally, all successful technologies are about democratization of access. All right? That's why we do this and why we apply this. It's the difference between a horse and buggy and an automobile. It's the difference between a fountain pen and a disposable Bic gel pen. The Bic pen gave the access to write to a lot of people who couldn't afford the equipment that it would have taken beforehand. Access, in this case, especially during the pandemic, and where everybody probably wanted me to talk about in this, was really seen in telehealth, but not necessarily by choice, and not because we are putting the patients first. And we heard in our first presentation in this session that overall, things have ended up in an interesting place. But in April of 2020, it was not so cut and dry. And before, at least in the United States, where we have some laws that actually govern and regulate how patients can interact via telehealth with their provider, it was not an easy system. In many cases, you would have to still drive to a secure clinic that had a Project Echo telecommunications setup, and if you were in a rural area, you could still travel to your doctor's office. Your doctor just wasn't there. And they would essentially, the equivalent of Zoom in at that time, and bill whichever rate for site of service was going to be higher probably in the end. But because those systems didn't exist everywhere at once, and patients weren't able to go to the doctor, a lot of institutions were starting to furlough clinicians. These are big, expensive organizations that aren't built for these kinds of lockdowns. And so ultimately, a lot of the requirements within the HITECH Act were put on hiatus, so we don't have to worry about that during the global health pandemic. They're starting to come back now that it's been officially declared over in the United States. But this has been an interesting grand experiment, and it has provided additional access to a lot of patients who otherwise didn't have it at all. And yes, not everything works well via telehealth. After open heart surgery, you probably do need to go see your doctor, but I broke a toe during the pandemic. They didn't care. They didn't want to see me, and they didn't need to see me. I was able to have a telehealth visit. I said, yep, all right, tap here. Did that hurt? No. Okay, yeah, you broke your pinky toe. And I was having a Zoom conversation with a clinician who was themselves homesick. And I don't know where the line is, somewhere probably between broken pinky toe and open heart surgery for what can still be done with telehealth. But we should probably start looking at that more in the hybridized manner that even the conference here has embraced, where in order to give proper access to more individuals, it has been opened up online. And that is actually a key point. Okay, I'm running low on time. I'm sorry. And so now I've lost where I was. The counter arguments really to this were that the indiscriminate utilization of telehealth services may widen disparities. There's a lot of evidence that seems to show that it actually is making more access a better thing for overall care, especially in mental health care, where that seems to be carrying on even after the pandemic is ending. The counter-argument that it jeopardizes the security of patient data, most end-to-end encryption is now baked into telehealth platforms. And the overutilization of care is an interesting point because security and access are always going to be on a spectrum. And if you want to take care of everybody who needs to be cared for, you're going to end up overutilizing it, quite frankly. The alternative is by locking things down, you're not going to care for some people who will need it. And you always have to take that principle into consideration when you're designing systems. I was going to talk a little bit more about where we're going in the world and why this is actually fundamentally important right now, and that comes to the fact that access patterns are about to change. I read a lot of reports, we'll breeze through this, related to human migration and what's going to happen, but before, when we were looking at EHR systems, it was pretty hard to get your data out. They're pretty incompatible with others, and even in the United States, and especially throughout Europe, it's hard to get access to your records, and if you can, the other system that you try to take them to may not be able to use them. There are rules and laws that are coming in to change some of this, but fundamentally, people are going to be on the move a lot more. It's hard to tell to what degree, but that is going to send a shockwave over the next 10 to 30 years, really, as different patterns of human migration take effect. And we are going to be faced with a problem where individuals now will not only have a choice of which healthcare system, but that system needs to be prepared to actually receive their information, process it, and do so in a way that will be beneficial to that patient. In the end, because again, I'm short on time, so forgive me for breezing through a lot of that. There'll be Q&A at the end. If you want to engage patients, ask them, talk to them, please. This is like my last slide, but thank you. But we've heard a lot of answers. We haven't heard a lot of questions so far, and I just want to encourage everybody here. I assume you're here because you have a share in this problem. Don't assume you already know what the patient's problems are themselves. You may know clinically, you don't know personally maybe. Ask them what care matters to them. Ask them how you can actually help them thrive, and ask them what their definition of that is to begin with. Because when you approach these solutions, are you solving your problem or are you solving theirs? Are you doing so and are you leveraging the technology that is coming about now in a way that actually prioritizes their outcomes? Or are you just counting the pain points? That's really the difference. So. Oh, yes. I'm supposed to introduce our next speaker. Sorry, I got really off there. All right, I'd like to introduce Rosalyn Conjo-Odero, who's been actively involved with rare disease community since her son was diagnosed with a rare disease. This unexpected journey, coupled with the desire to learn more, led to the co-founding of Rare Disorders Kenya. She combines her career in design management with her desire to empower patients in the rare disease community in that country and beyond. Please welcome Rosalind.
Thank you, everyone. Thank you, WPA, for this opportunity and for those who went before me. I'll be talking on mobile phone use in healthcare in developing countries. Now, mobile phones have disrupted our lives in a good way. We can't deny that. And there's a lot that it has happened, even in education and so many other things. So today I'm focusing only on healthcare and for most part, the public healthcare, rather than most people who are affected. So mobile penetration in developing countries is diverse. So we have more households owning a mobile phone than they have access to electricity and clean water, according to the World Bank report. And if you look at demographics as they go, as per GSMA, the Global Authority on Mobile Providers, so to speak, you find that in Africa we have about over 500 million people, subscribers of mobile phones, and most are using basic feature phones. However, in Latin America, you have most people using smartphones. So most frequent mobile health technology used is SMS. Every phone would definitely have an SMS, And then common health users, mobile health users, is preventative healthcare services, disease surveillance, treatment support, epidemic outbreak tracking, and chronic disease management. Now, let's look at the landscape of, developing countries in terms of healthcare. Now, there's a lot to say about healthcare in Africa, what's not happening. But I'd like to look at these common challenges that sweep across all the countries that we know of. So there's low doctor-to-patient ratios. The recommended WHO patient ratios is 1 to 1,000, but you find a country like Uganda would have 1 in 25,000. And the impact is that, of course, it will impact how care is given to patients. You have burnout with doctors, or you have less time with your patients. For doctors have less time with patients, it means that either patients will be misdiagnosed or underdiagnosed or given prescriptions that they don't need, or simply sent home and being told that there's nothing to be done for you. There's poor access to healthcare, the lacking healthcare equipment, medicine, and infrastructure. So either if the infrastructure is there, it doesn't serve the multitude of people. People have to walk many kilometers to just get into a facility. And even if you do get there, then there's no medicine. Or if the diagnostic equipment is lacking and you have to go to another town, and. Of course, there's limited allocated country health budgets to healthcare because of other priorities that governments deem important or are important. So despite all these challenges, we still have opportunities in mobile healthcare, and that can improve the service delivery in developing countries. So we look at providing quality care to large inaccessible population. During the pandemic, we would get messages about how to recognize signs of COVID, or what to do when you get COVID through SMS in the country. And for that person who's deep in the rural area and doesn't even know what we're talking about COVID, that's a huge difference. At least they know what to do, where to go for help, and all that. There's also providing targeted programs for healthcare workers or patients. In Kenya, we have a program called Text for Life, where it's a blood bank management system. The government believes that everyone should have the right to get safe blood. And how this works is that an SMS is sent and you're told that we need blood, and anyone who can be able to donate is able to get to the center. And after being screened, if you're found to have either an illness or something is wrong, they can still be able to manage you. Now, beyond that, even in Indonesia, there was a pilot program where midwives, midwife coordinators, and physicians were given mobile phones so that they can improve the efficiency in terms of communications between themselves, how they can even manage pregnant women, making sure that those who are at risk are screened before the midwife actually has to attend to them. And if when there is an unexpected emergency, how to have them referred or transported to the healthcare facility. There's also circumventing healthcare system challenges, which might be like drug stockouts. So with the use of mobile health technology, you're able to quickly find out which centers have drugs or what is going to run out, how do you replenish the stocks. And particularly in Ghana, this case is where Ghana was able to come up with an application that you check for counterfeit drugs. That's a rampant problem in developing countries where you have counterfeit drugs that can easily lead to death, of course. And so how this program works is a scratch code on drug packets, and you just key in the code, and it tells you if this drug is fit for use or not, and you simply get a message saying, okay, and thank you for buying the drug. And how this helps is because you increase your confidence in that you're taking the right drug. This program was successful and has been rolled out to other countries, including Asia, Nigeria, and East Africa. Other opportunities for mobile healthcare is that it breaks down existing gender and social barriers. Now, like in my country, sexual reproductive health is sort of like a taboo topic. You don't quite discuss it openly. Things to do with family planning is not something that you would easily, talk among people. And so this helps in a way, if you have a program that you need to increase the awareness or the use of family planning methods, you can use a phone and, you can subscribe, like in Tanzania, men would subscribe and you can get information about your family planning methods as a man. Now, as you would know, most men would not want to go to the clinics to get this information, to be seen they're going there, or they rely on their partners to give them that information. So if I can get that information on my phone anonymously, the most important thing is that you have that information and then what you do with it. Now, this works best if you have your phone yourself. Now, we'll look a little bit later that there's a bit of sharing of phones sometimes when there's an issue of cost. So you find in a family, instead of everyone having a phone, you can share a phone. So a family will have 1 or 2 phones. So that can bring another different dynamic, which we'll discuss about later. There's collecting and disseminating of patient data. Now, mobile health can be able to help us get quality data and be able to respond to this data in a timely manner, as opposed to the usual, rather what has been there that was paper-based. So you're waiting for this information to be put together by the end of, 3 months or so that you look at what's happening. But with mobile health technologies, you're able to respond immediately to growing trends and see what's going to happen. So in Rwanda, there's TrackNet, which is a system that was able to retrieve data regarding HIV/AIDS in the country. And it was one of the leading programs where the government has taken ownership, and it's actually hosted under the Ministry of Health. And how this works is that they're able to get information from the ground, from the communities in terms of HIV/AIDS and how many are there drugs enough. And if a facility is running out of drugs, you can be able to replenish those before you have a stock out and people don't have that. So you're able to sort of preempt what's going on and not wait for the problem to start and then you start responding to it. Another opportunity for mobile healthcare is that it attracts other health-related solutions such as MTIBA. So how MTIBA works is a mobile health wallet. So you're able to save money on your phone, and then you can use it to pay for medical healthcare in certain facilities. Now, that sounds like, why do you need to do it? But if you're living under $1 a day and you need to save for this money, or you want someone to send you money to spend on on your healthcare, you can easily have a place for it to be sent. And the government has already vetted certain clinics where you can use, MTIBA. And it's such a successful program that was rolled out to other countries such as Nigeria and hopefully also in Asia. Next up, Now, of course, there are barriers to mobile healthcare, and that, it makes people slow to adopt now. One of them is the financial feasibility of mobile health interventions. Now, of course, there's cost implications to this, and where you have, when you have to deal with people, you have to send, they need to respond to your messages. Let me get back up. Okay, so you subscribe to a program to get information. That means if it's only one-way communication, maybe you will not incur costs. But if you need that the patients to get back to respond, that means that there are mobile charges that will have to be incurred. Now, who incurs that? So most programs you'd pay for that. But of course that, the cost effectiveness, among other things, it might not be sustainable over a long period of time. So there's a cost implication, both on the people who are hosting this program and those who, that the patients or the community has to use this, whatever interventions that you're putting on the ground. Then, of course, there's the poor telecommunications infrastructure. So this works both ways. You might have a good telecommunication infrastructure, there's coverage and all that, but the people on the ground cannot afford a phone. So that brings in another dynamic. So either you have to get them the phone or, find another alternative, or that they have phones, but there's no network coverage. Many a times, we always make fun in my country, you have to look for a certain tree, you need to climb up to get better connection, depending on where you are. So, but that's kind of not, it's kind of getting better, but we always have those depending on which provider. So if behind people have several SIM cards, so on this area, like in my home, specific part of the, the house, I don't have network, and if you call me, you won't get me. But if I move to another side, then another carrier can give me, service. So there's always that, but they're working on it. But when you're looking at the whole a variety of countries, of course, these issues are compounded. There's also lack of adequate data to justify public investment by policymakers. So mobile healthcare interventions, yes, they work, but to what extent? So if I'm a policymaker and I have to decide how much I'm going to spend on something, I would go for something that has been true and tested, and I kind of understand that will work. But when it's something new and I don't know what the outcomes are, I will be a bit, shy to use it and to justify that. So you find that most policymakers would prefer traditional methods, which might take longer when maybe mobile health technologies would actually help, faster in getting data, among other things. Other barriers is the lack of data protection, privacy, and security policies. So most developing countries are aware of the need for these policies. Some are implementing, some are in the, getting to it. But what about compliance? So when you do not comply, then what happens? So those tends to be now where the issues lie in. And do you really want to, get into it as someone who's putting together a program? Now, poor integration with existing platforms is another thing. So you might have a good mobile healthcare solution, and it works well, but it can't be integrated with the already existing system where maybe it is paper-based. So do you then do something in between so that you can connect it? Then, of course, there's the cost implication, or do you still continue with what has been working for you? There's low literacy levels and the lack of digital skills. Currently, my mom is still trying to join into this since yesterday. So you understand the digital skills issues, and we've been trying to help her. And so these are the things that you find that in a certain generation that they'll having to understand how the phone works. Either they will rely on someone else to do that for them. And when that information is specifically geared for them, then you've kind of lost out. You need someone else to interpret it for them or, work them out. There's, of course, the social cultural barriers. And this is where I was trying to allude to earlier on, where you have issues like, for example, due to the cost of phones, people may not be able to afford. It means that we share phones. So that brings in issue of either privacy, and if I am a mother and I would like to know about family planning and that my husband does not accept it or does not understand it or does not want to, then you can understand that conversation, how that will be. I cannot share that information, or I have to constantly keep removing that information, or I don't want people to see that information. Other things is that with women, giving them a phone, who have a phone and you're empowering them with the information, it means that they start having a kind of autonomy and empowerment. That might not sit well with sometimes the men who are the decision makers in the family. So that might bring other dynamics. So whatever interventions are being put together, you have to consider the cultural norms and be very sensitive to what's on the ground. Do not copy-paste what's from somewhere else and hope that it will work in every community. You have to understand the dynamics of that community. In conclusion, there is great opportunity and promise in the phenomenal growth of mobile phone use in healthcare, despite the use of feature phones. So we've discussed about that most people are using feature phones, but despite that, we still are finding workarounds and to our own challenges. Locally relevant, innovative leapfrog solutions can improve the capacity of health system in developing countries. And we've seen that it does that, isn't it? There's a lot that can be done, and a lot of research that still needs to be done. Consider the characteristics of the population, such as the socioeconomic background, to gain a better perspective of the community. Again, do not copy-paste what works in India and bring it to Kenya, or take what happens in Kenya and hope it will work in Nigeria. Yes, it's a whole big continent, but we are all diverse and people with diverse characteristics. Finally, we have governments should seek to promote sustainable and cost-effective healthcare models that incorporate mobile-based service delivery methods. Most of the times you find that some of these programs are pilot programs, and then they're kind of hope that the government will pick them up and continue with them. Long term, it's not sustainable. There's a lot of cost involved, and it wouldn't work. So the government needs to consider having a public-private partnership that is long-term, that works to sort out some of these challenges. And finally, there's need for future research on how governments can help with their countries reach these goals. There's a lot of research that's lacking in this area, and that could help in moving this agenda forward. Now, thank you for your time. I hope I did not go over time. Thank you.
Thank you so much, Rosalind. And we're going to open it up to questions from the audience. So we do have microphones, and we can run those microphones out. If anyone has a question, please raise your hand. I want to mention that Anupam is available to take questions as well. He is online. So again, it looks like there's a question over here, Norma. Thank you.
Actually, this question's for you. I head up a national not-for-profit women's health organization, and we do a lot of work on women in chronic pain, looking specifically at sex differences. So I guess it's not really more of a question, but have you looked at just female-focused sex gender differences when you started your chronic pain program?
It's a great question, and early on in my career, I was really interested in sex differences too. When we look at chronic pain care, or even people seeking pain care, the majority tend to be women. And women will sometimes report higher levels of pain, other factors. But in fact, in my personal research, looking at interventions, we see no sex differences in patient response to the intervention. So that's really interesting. And sometimes, like in the spine surgery research, there's more men than women in those studies. In the breast cancer research, of course, it's all women. But when we look at studies where there's mixed, basically 50-50 men and women, there's no difference in treatment response. Great question. Thank you.
I have a question to Anupam Kashyap. He talked about LEAP. See, is it a platform or portal or app? And can you throw more light about this? How it works? How it can help in healthcare management, whether to the healthcare providers or the patients or anything. So please explain more about that.
So LEAP is a platform. It's an ecosystem to bring patients and all the resources that they need in one place. Right now, what the problem is, there are so many silos. I think a lot of our, my colleagues talked about, EHRs. There is a silo on EHRs. There are silos on education. You would see plethora of different solutions for different needs. So this is an ecosystem that brings all the resources at the fingertips of the patient, and it's driven by patient first. So first, it empowers the patients to have access to their data. So again, we are starting in US first because digitization of medical data has been great here. So we are able to leverage the data to understand the gaps in patients' care. So it will start with patients having access to their data. From that data, it will surface that what preventive screenings they are missing, and what are they risk at for what diseases, and based on that, they'll be connected to the best resources available who have evidence of resolving those problems, be it clinicians, be it content to understand, or be it food supply, be it transportation, whatever their barriers are, bringing all in one place. So that's what it is. And then I think that's the first phase. And the second phase is to predict diseases, because the future that we see is that why do we have to solve these problems downstream when the patient is already very sick? And, most of the digitization is on management. Why can't it be upstream where we can prevent? So yesterday we heard, story from Penny, and, she had to go through that heart surgery and then struggle, how to get what is adequate care? Where should I get it? How is it accessible? So why not just prevent it? Why does she have to go through that pain of that surgery or this, So again, I think that's the future that we should all work towards. So I think this is just one of our mission, and I'm so excited in the last 2 days, to hear so many things that I did not know about, and I think collaboratively we can do so much more. And I hope that answers your question.
Is it free or it will be chargeable?
Free. Free to patients, and there has to be some monetization model where the service providers will pay a fee, just like Amazon does. So because it has to be invested into research and development, but yeah, it is free for patients.
Can you share the link with the WPA office?
I will share that after that.
Okay, thank you.
Hi, this question is for Dr. Mackey. I'm just wondering, you talked about the IOM report. Is there any other follow-up from that to actually implement some of those findings? I know pain is really a big issue on the global level, and I've heard from some members here about how interested they are in more information. So is there any follow-up that you know of on the IOM report and the National Pain Strategy?
Yeah, I'm not sure. Is this one working? It is, you can hear. Okay. So let me just try to ground a little bit of this. The Institute of Medicine report on pain, thank you, came out in 2011, and it was a high-level 30,000-foot overview of the state of pain in the United States and where we need to go. And from that, we called for the development of the National Pain Strategy. This is now an action-oriented document about how to put into play the things put forward in the IOM Pain Report. Penny, by the way, co-chaired the public education working group arm of that. So props to you, Penny, for doing that. So the question is, have we implemented aspects of the National Pain Strategy? I'd say the most progress that we have made has been in the population research aspect, which is capturing better data on the nature of pain, the severity of pain in the United States. This is where we developed a new term called high-impact chronic pain to define pain that is having a significant restriction in your ability to take care of your day-to-day activities. And what we learned is that while 50 to 1 million 50 to 100 million Americans have chronic pain, or 1 in 3. 1 in 3. About 8% of people have high-impact chronic pain. Beyond that, we've made strides on the professional education aspect. There's been some working groups through the National Academy of Medicine. We've made some strides through some of the reimbursement aspects and reimbursing non-pharmacologic, non-procedural-based care. But here's the kicker, and I could go on about this, but I won't. We need to do more. So part of the vision, part of the issue is that we need to get our policymakers, our legislators, buying into this. And they're the ones who hold the purse strings and can do the apportioning of money to make these things happen. And what they need to hear are the patient voices, the people with the lived experiences, and Penny's been very effective at this in the United States, and we need high-quality data to guide this as well. Because frequently these legislators are saying, well, what's the data behind this? And frequently, at least in the chronic pain area, we don't have good quality data. So I would submit to you it's a combination of bringing together high-quality data and then bringing the patient voice, combining those, and then hitting our legislators very hard and saying, you got to do something about these problems. What are your thoughts, Penny? You were knee-deep in the National Pain Strategy. Putting it back on you, what are your opinions?
Superman. You know, I think the patient voice is always critical to anything, and they're going to probably have more power than anyone else because we're living it. But the problem is so many of them we can't reach them because, you know, they're so isolated, especially with the COVID issue right now, you know, that they're just not online. They're just not available. They're not going out there. But I think what's really important is to get more organizations, because even though pain seems to be its own little subset, I think all of these organizations, not only on the national level here in the US, but globally, everyone is dealing with pain. So we need more information, more patient education, more government involvement in supporting all of that. Because if you can address acute pain appropriately and give providers enough time to do that, because time for providers is another issue, and I won't go into that either. You know, I think we can prevent a lot of chronic pain. So I think that's one of the important things, is looking at acute pain, not just chronic, but acute pain as well. And I think a lot of these diseases, and we heard that from the mothers of I forget what the session was called, but medical errors, yeah, that, you know, that was one of the issues right there, is because they're just not, we don't have the right information, they're not either educated, they're not taking the time. And I think that's very true with pain. And when Beth asked the question about women, I think that's one of the things that we need to work on, because they're not believed as much as men. And I think that's been a real issue. And I think that's one of the reasons she asked that question. But I think we need a lot more involvement. So I'm hoping that in 2023, and this is a part of my next session, that we focus more on pain and pain management and get more people involved so we can get those patient voices out there, not only in the US, but on a global level.
Well stated. Well stated. And, you know, Penny brought up the IOM Pain Report, the US National Pain Strategy. There are other countries that have pain strategies. Canada has one, Australia has one. I've read them all, and I will tell you, it's the same darn language. Like, the people in all these countries, we're all facing the same problem. So why don't we all work together to find solutions to this same problem?
So, Paul Barish from the U.S. Jacob, thanks for raising and trying to slaughter a few sacred cows in one short presentation. The real question is, before the disease of EMR spread to the rest of the world, given the perverse incentives in which EMRs are designed, and I 100% agree with you, is it still possible in countries that are embracing the benefits of digital health not to follow in the same trappings of the money-driven EMRs in the US? This is a serious question, which is, can innovation grow from the lessons of unholy innovation, if you will? And how do we make sure we don't have these perverse incentives that further drives the problems that we're finding in the US, where EMRs have increased the workload, increased the burnout, undermined the joy of providers, primarily because they never listened to the providers in designing the systems?
A lot of those reports also highlighted the means in which kind of the arbitrary system fundamentally changed the interaction that clinicians have with their patients. It's not speaking to and working through that problem together and putting it down in your own words, what they said in their own words. It starts to try to categorize all of that in the moment instead of interpreting that and standardizing that later. The incentives point is, it's a good question to ask, but I don't have that answer because there's always going to be a shift towards essentially maximizing the incentives for the minimal input in any of those systems. And when it comes to the EHR part of it, it already has spread. I think what we're looking at is EHR 2.0s. We're looking at trying to fix a lot of the things that have gone wrong in that implementation process. And my appeal is essentially, please, if you have any stake in that, engage the people whose lives will be affected by those processes. Talk to the clinicians about what they need as a tool to enhance their patient interactions. Talk to patients about what actually matters to them in their care, and then find a way to support that. I think that is fundamentally what has to be done, and no one meant to do it wrong the first time. Everybody tried really hard to get it as bad as it is now. And I think that more so you're going to see innovation related to our last presentation when it comes to mobile health technology and telehealth, and you're not going to see it in the United States, and you're not going to see it in mature markets because we already have the rules and regulations mandating how it was done currently. So I think that the places that are not as regulated are going to be freer to embrace and experiment and develop new solutions that will then start to spread. And it's not until it is already almost the ubiquitous answer will it come back to the established markets, and that we will adapt to newly proven technologies there.
Thanks. And then I have a question.
I'd love to add here, because I come from this world of, can everybody hear me?
Yes, Anupam.
All right. So I have lived that, EHR. I come from an EHR background, so I know exactly the problems and the solutions. And absolutely right that EHRs had an unintended, outcome of provider-physician burnout. And it's because, again, physicians were not consulted while designing these systems. They were heavily engineering-driven decisions. So there is a solution. I think there are some companies like QRMD that are working on the 2.0 version, which is completely a different user interface. It's a voice-based interface. So there's no keyboard, there's no typing. It's listening to the conversation between patient and provider and translating that into structured data that can be used. And again, other thing I would say is that even though we see the problems with EHR adoptions, but it has resulted into data that now can be used to improve health. Now there is interoperability because of that. Now there are standards, and now that data can drive better outcomes. So I think we need to learn, but also with new technologies like the computer vision and OCR, I think in other countries, we can get to that endpoint of data-driven decisions without having to implement the way EHRs were implemented in US. So you can convert that data from paper to digital in a way that can then drive these patient-driven, better outcomes. So I think there was a benefit of implementing in US, which we all learned from.
So my follow-up question to Dr. Mackey was, so I was on ground zero now in my head as an anesthesiologist, how the Joint Commission's seemingly fifth vital sign seemed like a really good idea, and watched how we overprescribe narcotics. So the real question is, what are the lessons to be learned from how we as groups trying to get governments to help create more regulations? The unintended consequences are that close to 10% of post-surgical patients have short and long-term addiction. This is not happening in other countries, Beth, related to your comment, because they don't have that Joint Commission fifth value, for example. It's one of the reasons. And so we created a system where we push clinicians to give more narcotics, and then now we're trying to deal with the consequences. So the real question is, how do we make sure that we think very carefully about getting governments to pass rules around pain that don't actually create unintended further problems that later on lead to 20 years later trying to clean up the mess? And one could argue up front that this was predictable. That is to say, the idea that you'd have surgery and have zero discomfort, which is what was promoted in the US, was guaranteed to lead to a lot of unhappy patients and providers, versus this idea that surgery is in fact a highly discomforting process. And while pain can be mitigated, the idea that you'll have zero discomfort whatsoever has a price to be paid for. Any thoughts on that?
That's a lot to unpack. And it's a really deep question, and for those of you from other countries, the Joint Commission set many of the hospital standards for how each hospital in the U.S. has to operate, and if you wish to be accredited, and of course everybody does. And back in the day, there was put forward a model for people to monitor pain much like you monitor temperature, blood pressure, heart rate in a hospital setting. And it has been attributed, this pain is a fifth vital sign, it's been targeted and attributed to the reason why we have an opioid crisis, or at least in large part an opioid crisis in the United States that isn't present in other countries. And I get it. I actually think that the real answer is much more nuanced and complex than that. Did it contribute in a way to the problem? In other words, by asking patients about how much pain you have after surgery, was there incentives, was there pushes to do something about the pain, and did that lead to more people being prescribed opioids? Yes, that was an unintended consequence. But you have to also factor in all the other things going on in the United States at the same time. Production pressures on physicians to see more patients in less time. And if you're dealing with pain, you know it's complicated, and one of the best things that you can do as somebody caring for pain is listen to people, and that takes time. And we had time taken away from us. Number two, we had a great push in the United States to get people out of the hospital immediately. It used to be, and it still exists to some extent in European countries and others, that you camp out in the hospital after surgery for a period of time. In the US, everybody was out the same day. And so what you're trying to do is predict how much pain a person is going to have when they leave the hospital. We're not that good. So what we do is we give them a handful of pills, and we say, good luck to you. And we give them more than they need because we don't want to be called at 3 a.m. when they run out of meds. So we give too much. We clearly gave too much. So I get it, and it clearly contributed. But let me run the counterfactual for you. Do you want to go back to a time when we stopped asking patients how much pain they had after surgery? I submit to you, no, that would be crazy. Don't we want to know if somebody after surgery is in pain? And obviously the answer is yes. What we have to do are find ways to do it that appropriately set expectations, as you said. And the Joint Commission has ultimately modified the questionnaires that they ask patients. They've evolved from how was your pain really well managed, to have they communicated about pain, and now they've even cut back on those. We have a lot to learn in this, and I'm going to come back to the prime message of this conference is we have to all work together, patients and physicians and the policymakers, to find the appropriate questions to ask people after surgery to try to reduce those unintended consequences.
So just briefly, and taking this to a principal's perspective real quick, does anybody know what Goodard's law is? Am I the only one in the room that studies weird, obscure things like this? Okay, so basically the principle is that when a measure becomes a target, it stops being a good measure. So In this instance, there's one thing to ask the question, because you wouldn't have known the answer before, and it hadn't been asked enough. But to try to then use the aggregate of that information to drive policy, to direct funding, now you've created a system where that is itself a target, and anything less than 100% is now not good enough, so you give more than enough to make sure that you're being adequate because you've warped that system.
Yeah, and I'm going to just build on this briefly about one other thing that happened in the United States that we haven't touched upon was patient satisfaction scores driven by Press Ganey, in my opinion, so I don't get sued. Everybody introduced this concept of measuring patient satisfaction and driving the patient satisfaction scores up as high as possible at all costs. And it was much easier to give a pill to get those satisfaction scores up than to listen to patients and talk with them and find out what's really going on, again, in my opinion.
So I just want to add to what was a really excellent question that a substantial fraction of this goes back to treating the person and not focusing just on a symptom. And so, you know, until very recently, all we could offer people was a pill. But we have new options. And so, you know, I discussed some of those. I mean, we can educate physicians, we can educate patients, and we can give them treatment options before their surgery, in the hospital after their surgery, or at home, so that people can simply focus on recovering with greater comfort so that they can get back to doing the things they love. So that's not reductively focused on a number, even though the number is important, but it's the messaging and how we focus both the healthcare's attention and also the attention of patients and families and consumers, that this is about optimizing your outcomes. And if we take this whole person approach, we can help you recover quicker with greater comfort, get back to doing the things you love, because that's what really matters.
Yeah, so I'm going to come back. Like I said, great question, and it's a lot to unpack within that single question. You know, the good news is 20 years later, we have come so far with the treatment of pain. It's gone beyond just an opioid or a tricyclic antidepressant or an NSAID. We've now got therapies that are on demand. We've got over 200 medications we can use, mind-body therapies, physical, occupational therapies, interventional approaches, a lot more tools to wield. We just don't know which patient they work for. That's why coming back to the need for high-quality data.
And it looks like there's another question over here.
As a patient, I'm not a consumer. I didn't choose to get sick. I'm sick, right? Okay. Do no harm is my physician obligation to explain to me before the prescription. It's not my job. Health safety, we said before. It doesn't matter how much the system is pressuring to see 100 patients in one day. You know, it's do no harm. We can blame it to the pharmaceuticals, we can blame it. Who is the prescription behind it? And I'm not talking about the pain specifically or to go into that specific category. Do no harm. You are there to protect me, whatever is telemedicine, whether it's via phone, whatever. Is my physician, is the specialist. And we can have a system which is totally business-like, and that's why I don't like, with all my respect, the terminology consumer. I didn't choose to be sick, I'm sick, that's it. Who is gonna protect me? Yes, I educate myself. Health safety, yes, the system is pressuring the healthcare providers. I'm with you all the way. But you have to explain to me whatever is pain, or it's just a Panadol, or whatever is aspirin. You know, you have to educate me the minute you give me that bottle for whatever disease. It's very nice, and I'm next to, we all should work together, but nobody listens to us. If I ask, and you say, sorry, I have no time, what do I do?
You're right. It's as simple as that. You are right. So how many of you don't like being called consumers? Okay. Ask how many of us physicians do not like being called providers? I hate being called a provider. I'm not a provider. She's not a provider. The consumer term and the provider term came about through the business people to industrialize healthcare. It's to disempower us and turn us into units that can be manipulated. And we need to take it back. You know, whether you are a patient or a person, what Penny taught me many years ago is, you know, a person with pain or a person with diabetes or a person with heart disease. And we're not labels, either one of us. And you're right, again, do no harm.
I would just want to ask Rose if she can tell us more about some of the barriers to mobile phone use for healthcare, just very broadly, but you may want to focus on sub-Saharan Africa as well.
Okay, so barriers to phone use in sub-Saharan Africa. Okay, mobile health, okay. Most of them I covered them. Okay, so I'm trying to think how to answer that. So a lot of it I've covered, but there's the issue of the cost, of course, the cost of mobile phones. Not everyone can be able to afford, but the other way of doing it is just the sharing method. But beyond that, of course, the connectivity. Not everyone is connected. So even if you have these interventions, then if there's no connectivity, then you don't reach these people. Then the issue of security concerns with, you know, your mobile. Is it safe? Can someone take it away from you? Or can I be able to manage the costs of, you know, paying for the tariffs or for the, you know, for the service, among others? Is that what you're looking for?
Are there different languages? Forgive my
It's okay. It's okay.
How many different languages are there, and how much illiteracy is present if you're trying to communicate healthcare concepts over the phone?
So how many languages are there in?
Pick an area.
Okay. Like in Kenya, we have 42 languages.
How many?
42.
42?
When you go to Nigeria, there are 110. And that's just two different countries. Of course. And that's why, like in Kenya, we have English is the official language, and then we have Swahili. So any communication will be in those languages. But beyond that, a certain level, a certain age, they will be preferring their language, or they would understand more. Or it will be an issue of how do I navigate through the phone. So those are some of the challenges.
Okay, thank you. I go on. About patient safety, there is the clinical trials, and patients are used for these clinical trials. Now, how prepared are they usually? What preparation are they given them and their family? And in the event that there are dangers that they face, is there any compensation for them and even their families? And are they well prepared in advance and properly advised?
If I understood the question, you know, in clinical trials, to what extent are people really informed about what they're getting into? And secondly, are they compensated, and how well are they compensated? Oh, if something goes wrong?
Yeah, if something goes wrong.
Yeah. Yeah. First question, incredible variability. And I wouldn't be doing your question service if I just told you what we do at Stanford, because we don't represent the real world. I mean, we highly explain to people what's going on and get informed consent, and we pay people really well for the clinical trials. I don't know how it goes on in Kenya and how it goes on in other countries. It's going to be highly variable. And the second, you know, are patients' families compensated if something goes wrong? Not typically. In most cases, the funder doesn't have it's not built into the model. Like the National Institutes of Health that funds a lot of our research doesn't have models in place to compensate people if something goes wrong.
Just very quickly, I just want to add, I mean, I can only speak to what we do at Stanford, part of the consent form is saying, listing out the potential risks. There is, the Institutional Review Board in the United States, where it has to go through a rigorous, both academic and also often a patient peer review board to ensure that the risks are commensurate with the research, or that there are all of these patient protections. It's a human safety board. Again, I can't speak to other countries, so I'm going to turn it over to Rosalind. She can educate us.
So I sit on an ethics board for one of the largest children's hospital in Kenya, and what you're talking about is actually implemented. And even in Kenya, that has become a major issue, that you have to have a proper ethics certificate and ethics. You've gone through the rigorous process, and so it ensures that one part of the consent forms, or when they apply for these clinical trials process and all that, you have to ensure that there is compensation in case something like that happens. So they have insurance for it. So you look at adverse, they're called what? Adverse reactions, what's the word again? There's a word for it. So when something like that happens that is really bad, like, even you die, there's compensation for it. So those are there. But I know that in some places it's not quite followed, and people abuse that and take advantage.
Thank you very much.